Welcome to the Explainer. This is your lightning prep guide for the IBCLC exam.
Okay, let's dive right into a critical clinical scenario you are absolutely going to encounter. This is a topic where your expertise can truly make all the difference for a family.
So, here's how we're going to break it down. We'll look at 4 key areas that are going to give you a complete toolkit for your exam and for your practice. We're talking anatomy, principles of care, the actual hands-on strategies, and of course, the tools you'll need.
First things first, we have to understand the fundamental mechanical problem these babies are facing. Grasping the why of it all is the foundation for every single intervention you're going to make. It is so crucial to tell these two apart. A cleft lip, that mainly messes with the baby's ability to get a complete seal, which makes the latch itself pretty tricky. A cleft palate, though, well, that's a whole different ballgame. It presents a much bigger mechanical hurdle because it hits the core mechanic of feeding, generating that pressure.
And here it is. This is the absolute heart of the issue. It's not about a weak suck, okay? It's a mechanical impossibility. The baby can still compress the breast, for sure, but without that sealed-off mouth, they just can't create the vacuum that's needed for effective milk transfer. It's a physics problem. And this really puts the challenge into perspective, doesn't it? A success rate for direct breastfeeding that can be as low as 0%. That single statistic just hammers home why your expert intervention is so incredibly vital for these families.
Okay, so we know the challenge. What are the foundational principles of care that you need to apply? This is all about setting the stage for success, whatever that success might look like for each unique family.
Your role here starts way before anyone even tries to feed. It kicks off with expert, evidence-based counseling, setting realistic expectations based on the specific type of cleft, while at the very same time hammering home the huge protective benefits of human milk, especially when it comes to lowering the risk of infections like ear infections.
All right, let's get our hands dirty and move into the practical strategies. This is all about building up your clinical toolkit. These are the hands-on techniques you'll be teaching and fine-tuning with families.
Now, before we even look at the specific holds, you have to remember the goals. What are we trying to do here? We are actively compensating for the baby's inability to create suction. And we do that by making gravity our best friend, by positioning the breast tissue to almost act like a plug for the cleft, and by using our own hands to provide that extra stability.
This table right here, this is your go-to reference for the exam. Seriously, the upright or koala hold is often a total game changer because it uses gravity to your advantage. It helps that milk flow down into the stomach instead of up into the nasal passage, which you can imagine dramatically cuts down on nasal regurgitation and distress for the little one.
The dancer hand. You have to have this technique in your arsenal. It gives that external stability the baby's jaw and cheeks need to effectively squeeze the breast and get the milk out, since they just can't rely on suction power. But, a lot of the time, even with perfect positioning, direct breastfeeding just isn't going to meet the baby's calorie needs. And that's when we need to bring in the right tools for the job. And this brings us to a super important part of your counseling, knowing when direct breastfeeding isn't enough. It's all about confidently shifting to alternatives while still making human milk the priority. In this case, success isn't just about latching. It's about an infant thriving on their parents' milk, no matter how it's delivered. So these devices, they are specifically designed to deliver milk without needing suction. They rely on the baby's own compression of the nipple and sometimes a little gentle help from the caregiver squeezing the bottle. The whole point is to make feeding efficient and a lot less tiring for the baby. This quote just hits the nail on the head, doesn't it? It gets right to the heart of our role in prenatal education. It is all about managing expectations from the very beginning. The goal is always human milk and that beautiful nurturing at the breast, but we have to be crystal clear that the method might have to be flexible because ensuring that baby's health and growth is non-negotiable. So, what's the big takeaway here? As an IBCLC, your expertise empowers families to get through this really tough challenge. You're the one who protects the milk supply, teaches these specialized techniques, and supports that parent-infant bond. You make sure the best possible health outcomes happen by keeping that vital connection strong. So the real question to carry into your practice is this: how can I help every family redefine success, moving their focus from just the feeding method to that unwavering goal of nourishment and connection?